All right. Hi, good night, everyone. My name is Teresa Soifat. I'm a host officer attached to Port of Spain General Hospital, and tonight I'll be presenting on the management of pineal gland tumors. So, the pineal gland is a small pine cone-shaped neuroendocrine gland. It's a midline structure that's attached to the stalk of the posterior wall of the third ventricle. The mature pineal gland is made up of pinealocytes arranged in lobules forming the pineal parenchyma. The arterial supply to this gland is mainly the posterior choroidal arteries, and the venous drainage is via the internal cerebral vein. The gland also contains endings from sympathetic nervous innervation to the pinealocytes, with epidermal cells of the third ventricle adjoining the gland along its anterior border. The primary function of this gland is the secretion of melatonin, which regulates the circadian cycle. Now, in this gland, due to varying tissues, there could be a diversity of both neoplastic and non-neoplastic lesions arising from the pineal region. Now, for epidemiology, pineal gland tumors account for less than 1% of CNS tumors in adults. It's actually more common in children between the ages of 1 to 12, with approximately 3 to 8%, it being 3 to 8% of pediatric brain tumors. Pineal tumors are more common in Asian countries than in Western populations, and they are substantially more common in males. Etiology. Most cases are sporadic in patients without risk factors for neoplasms. And some pineal parenchymal tumors arise in association with genetic tumor predisposition syndromes such as hereditable retinoblastoma, familial adenomatous polyposis, or even Cowden syndrome. Moving on to the types of pineal gland tumors. So the three histological tumors which account for most of the neoplasms arising from this gland. They have germ cell tumors, pineal parenchymal tumors, and gliomas. Benign lesions can be also found arising from this gland and can be confused with neoplasms, and these include pineal cysts, vascular malformations, and vein of Galen aneurysms. So this table here just shows a breakdown of the germ cell tumors, of the breakdown of the tumors found in a region, and the percentages. So we have germ cell, pineal, parenchymal tumors, and uncommon are the astrocytoma, meningioma, lymphoma, trilateral retinoblastoma, and even metastatic. Right? Germ cell tumors. Now these tumors could be divided into germinomas or non-germinoma matters germ cell tumors, according to the WHO classification system. The non-germinomatous germ cell tumors include embryonal carcinoma, endodermal sinus tumor, which are yolk sac tumors, choriocarcinomas, teratomas, and mixed tumors with more than one element in them. Germinomas and teratomas are frequently encountered as pure tumors, and other types are mostly part of mixed germ cell tumors. Now, intracranial germ cell tumors typically appear hypointense to isointense on T1 weighted images, and they appear hyperintense on T2 imaging. And they have contrast enhancement pattern. Their contrast enhancement pattern, could be homogeneous or heterogeneous. With respect to germinomas, approximately 75% of all germ cell tumors and approximately 45 to 50% of all pineal tumors. They are homogeneous, hyperdense masses. The peak age is usually 10 to 30 years of age, with it being more common in male than female. Approximately 10% are found in the pineal and suprasellar regions, and 15% are associated with an increase in serum beta-HCG. Imaging is the modality of choice for imaging is MRIs. And MRIs would show localized calcification in about 70% of germ cell tumors, while it is peripheral and scattered in more than 50% of pineal parenchymal tumors. There could also be bithalamic extension of the tumor, seen in up to 80% of germinomas, while it is significantly rare in other groups of tumors. These tumors are highly radiosensitive, and treatment is with radiation to the entire neuroaxis. So this table just shows the WHO classification and, well, definitions of germ cell tumors found within the central nervous system. And as we can see here, we have germinomas, mature and immature teratomas, teratoma with somatic type malignancy, embryonal carcinoma, yolk sac tumors, choriocarcinomas, and even mixed cell germ tumors. Teratomas now. These are the second most common pineal germ cell tumors, and they contain tissues from all three layers. They display elements such as skin, nerve, cartilage, bone, fat, muscle, respiratory glands, and even GI glands. In these teratomas, serum CEA levels may be elevated. Teratomas are also multilocular heterogeneous masses that can contain lipid areas. Now, this table just gives us the grading of CNS tumors, which we would see with respect to the pineal parenchymal tumors. So it ranges from grade 1 to grade 4, grade 1 being low proliferation, and they are they have the possibility of cure after resection. And as you go along the grading system, they become progressively, the prognosis is worsened. So grade 4, malignancies with high mitotic activity that are prone to necrosis, and these tumors tend to have a poor prognosis with fatal outcomes both pre and post-operative disease. So pineal parenchymal tumors, these could be divided into 4 groups. There are pineocytomas, which are classified as grade 1, pineal parenchymal tumors of intermediate differentiation, which range from grade 2 to 3, papillary tumor of the pineal region, which is grade 2 or 3, grade 1 or 2, sorry, or pineoblastoma, which is grade 4. So pineal parenchymal tumors. So these are rare, well-differentiated tumors. Histologically, they show pineocytomatous pseudorosettes, which are characteristic for these tumors. The peak age is approximately 30 years, and there's no sex predominance in this type of tumor. Immunophenotypes for this tumor include synaptophysin positive, neurofilament positive, neuron filament positive, and NUN negative. Again, the imaging of choice is MRI for these tumors. The T1 weighted images show a hypo to iso intensity to the brain parenchyma. T2, which shows solid components, which are iso-intense to brain parenchyma. And they could show areas of cystic changes, which is usually common, because sometimes the majority of these tumors are cystic. They comprise 25% of all pineal parenchymal neoplasms. And prognosis-wise, they have a 5-year survival rate of approximately 86 to 91%. In these tumors, metastasis or CSF dissemination is rare. Now, this is the diagnostic criteria for pineocytomas. So we see here, for the criteria, these tumors must demonstrate pineal parenchymal differentiation by histopathological and immunophenotypic features, such as the positivity for the synaptophysin. There also must be the absence of criteria qualifying them for the diagnosis of pineal parenchymal tumor of intermediate differentiation or pineoblastoma. There must be low proliferative or mitotic activity, and they must also be located within the pineal region. The next one is the pineal parenchymal tumor of intermediate differentiation. So Pineal parenchymal tumors. These are pineal parenchymal tumors with clinical and biological behavior intermediating malignancy. So that's between the pineocytoma and the pineoblastoma. The mean age of diagnosis for this is 41 years, with a male to female ratio of approximately 1 to 1.25. MRIs for this usually show a larger, more heterogeneous lesion than the pineocytoma. It would show rapid growth and or low ATC value, which could differentiate it from pineocytomas. Histologically, it would show lobulated and or diffuse patterns, and the immunophenotype for this would be synaptophysin positive, NUN negative, or NFP variable. The diagnostic criteria for these tumors, they must demonstrate pineal parenchymal differentiation by histological and immunophenotypic features. They must have increased proliferative or mitotic activity. There must be absence of criteria qualifying the diagnosis of a pineoblastoma. They must be located within the pineal region, as well as DNA methylation profiling should align with these tumors. There should also be molecular demonstration of the KBT BD4 in frame insertion, which is highly desirable for these tumors to meet the criteria. The next is the pineoblastoma, which is WHO grade 4. Now, this tumor is the most aggressive and it infiltrates surrounding structures. It also has the tendency to disseminate in the CSF, and it can metastasize to bone, lung, and even lymph nodes. They are malignant, they are highly cellular, and poorly differentiated embryonal pineal parenchymal tumors, and they constitute approximately 35% of pineal parenchymal tumors. They have a mean survival rate of less than 2 years, with a peak age of less than 20 years. The male to female ratio is approximately 0.7 to 1, and these tumors are associated with hereditary retinoblastoma. The immunophenotypes for this are synaptophysin positive, specific enclosed positive, and a smart CB1 positive. Pineoblastomas are hyperdense on CT and have no associated calcifications. On MRI, they are usually larger than 3 centimeters, lobulated, and poorly demarcated. They are iso-intense to gray matter on T2 weighted images. Indicators of poor prognosis for these tumors would be disseminated disease at the time of diagnosis, a young age of a patient presenting with this diagnosis, and partial surgical resection. The diagnostic criteria for this particular, for pineoblastomas, they must have histopathological features of an embryonal tumor. They must have high proliferative or mitotic activity. They must be located in the pineal region. And it's also desirable that there be retained nuclear smart CB1 staining and DNA methylation profile of one of the pineoblastoma subtypes. The next tumor is the papillary tumor of the pineal region. This is classified as a WHO grade 1 or 2. It's a neuroepithelial tumor that has papillary and solid areas, and it's comprised of epithelial-like cells that show immunoreactivity to keratins. It affects both adults and children and has a median age of approximately 35 years. Imaging for these tumors would usually show well circumscribed lesions with cystic and solid components. The T1 weighted imaging would show hyper intensity with heterogeneous enhancement. And prognosis for this is low recurrent, There's gross total resection. If there's gross total resection and younger age and presentation at a younger age, these are actually better indicators for better prognosis. The diagnostic criteria for these. So these tumors must have a papillary growth pattern with epithelial-like cells. There must be characteristic immunohistochemical staining pattern. They must be located in the pineal region, and also confirmatory DNA methylation profiling. The next type of tumor that can arise are glial tumors, and these typically arise from the tectal plate. The usual appearance of these tumors is multilobular. It's a multilobular solid tumor, and it has indistinct margins with heterogeneous contrast enhancement. The enhancing tumor could be distinguished from the surrounding hypointense signal of edema on T1 weighted images. Examples of these tumors include astrocytomas, oligodendrogliomas, and glial cysts. Other tumors that could also arise are meningiomas, which are usually small, less than 2 centimeters. They are well defined. They have well defined margins, and they arise from the arachnoid cells. And they could also be the presence of pineal metastases. Clinical features of pineal gland tumors. So patients could present with hydrocephalus, which is usually obstructive, and this would be due to compression of the sylvian aqueduct. If there's hydrocephalus, they could present with symptoms such as headaches, nausea, vomiting, lethargy, a change in GCS, papilledema, ataxia, and for infants, there could be presence of abnormally increasing head circumference. Now, if there's direct compression, of the midbrain, particularly at the level of the superior colliculus, this could cause disorders of extraocular movement, classically known as Parent syndrome. Now, this affects branches of the posterior cerebral artery, and it results in a vertical glaze palsy. It could eyelid retraction and convergent retraction nystagmus. Patients could also have neuroendocrine disturbances. So there could be the presence of precocious puberty in boys with germanomas or choriocarcinomas. And suprasellar germ cell tumors could present with the triad of diabetes insipidus, visual defects and deficits, and panhypopituitarism. Patients could also present with spinal symptoms, and this could be due to metastases or from CSF seeding, like things that would be seen in pineoblastomas. Now, this table just give a summary of the signs and symptoms of the pineal tumors and the percentages. Next, we have the management of these pineal lesions. So we always start with history and examination for these patients. After which we go on to investigations, and these which include lab investigations, CSF evaluation, imaging, and biopsies. And then there can be surgical intervention plus or minus adjuvant therapy. Investigation. So tumor markers. Now, tumor markers are important in assessing these lesions. So the presence of alpha fetoprotein or beta HCG, whether it be in serum or CSF, is characteristic for malignant germ cell tumors. CSF levels, though, tend to be more sensitive than serum levels. So alpha fetoprotein indicates the presence of a fetal yolk sac element, and beta HCG, if they're high levels, the high levels are usually found, in choriocarcinomas, but could also occur in up to 50% of germanomas. Now, the tumor markers are also useful for monitoring the response to adjuvant therapy or as an early sign of recurrence. With respect to imaging, CT scans. Now, most patients have initial CT scans due to symptoms of obstructive hydrocephalus. Next would be MRIs, which are the modality of choice for pineal lesions. These are usually done with or without contrast of both the brain and the whole spine to assess for METs. They could also be used to identify tumors and relationship to adjacent structures. The next investigation can be done is biopsies. So this could be done via different approaches. There's the transventricular approach, which is usually if a hydrocephalus is present. There's open biopsy, there's stereotactic biopsy, and with this you have two approaches. So you have the anterolateral approach, and then there's the posterolateral transparieto-occipital approach. Then there's also navigation-assisted endoscopic approach, which has various approaches, including the infratentorial approach. Now, this approach is typically combined with a third ventriculostomy for CSF diversion. We'll just go into a little more detail on stereotactic biopsies. So stereotactic biopsies offer the advantage of a relative ease of performance and reduce complications when compared to open procedure. It would also allow us to aspirate for cystic masses. Now, these stereotactic biopsies require contrast-enhanced MRIs. They also carry a risk, though, of hemorrhage, so bleeding in highly vascular tumors, damage to the venous system, or if there could even be the presence of bleeding into the ventricle. Treatment of pineal tumors. So surgical resection. Gross surgical resection usually only required for pineocytomas, and they're also preferred for pineal parenchymal tumors of intermediate differentiation. Then is gross total resection with multimodal therapy, and this is associated with very favorable outcomes. Another treatment option is radiation. So this is adjuvant radiotherapy, and it's important for all pineoblastomas in children greater than 3 years of age. Many pineal parenchymal tumors of intermediate differentiation and most subtotal resected pineocytomas. The next option is chemotherapy. Now, this is used as part of a multimodality therapy, example in pineoblastomas. It has been used in children to delay radiotherapy due to long-term neurocognitive and developmental side effects of craniospinal irradiation, but it's not really used very often because it has some disappointing outcomes. Surgical management. So what are our options with surgical management? We have direct surgery, where we could do a generous tissue biopsy. This could be curative for benign lesions, but it's not best for malignant tumors or germinomas without complications. We also could do biopsies of lesions followed by adjuvant therapy, which is the preferred management. What are the indications for surgery? With pineal gland lesions, surgery is indicated for tissue diagnosis if there's the presence of obstructive hydrocephalus. So this may require immediate CSF diversion procedure, or EVD. If there's a mass effect and symptom relief, and we're looking for symptom relief, so example, if there's severe compression of the tectal plate, it's indicated if you want complete resection for benign or low-grade tumors like the pineocytomas, and also for mixed or non-responsive tumors, example, malignant germ cell tumors that are resistant to radiation or chemotherapy. Surgical approaches. Now, the choice of the surgical approach must be guided by a pre-op MRI. And the surgical consideration we need to take into mind here is that due to the location of the pineal gland and the deep cerebral veins being a major obstacle, We must preserve venous drainage. Now, open surgical approaches. Advantages of open surgical approach. There is the ability to obtain larger amounts of tissue and more extensive tissue sampling. Now, the extensive tissue sampling is particularly important in this region, because they're in this region in general, and with germ cell tumors in particular, because of the heterogeneity and the mixed cell populations which are common with these lesions. One clinical advantage is that the tumor burden is reduced with an open procedure. So for one third of tumors that are benign, resection is usually complete and curative. Open surgery in patients with mild hydrocephalus whose tumors can be completely resective can negate the need for CSF diversion via VP shunt, etc. Approaches to the pineal region are categorized as supratentorial or infratentorial. Now, the supratentorial approaches would include things like the transcallosal or transcallosal interhemispheric, the occipital transtentorial, and the rarely used transcortical transventricular. The infratentorial approach is through a natural corridor created between the tentorium and the cerebellum. So large tumors that extend supratentorially or laterally to the trigone of the lateral ventricle, these generally benefit from the supratentorial approach. The supratentorial approach affords greater exposure when compared to the infratentorial approaches. And but they do have the disadvantage of forcing the surgeon to work around the convergence of the vein of Gland and the internal and cerebral veins when they manipulate to resect the tumor. Now, the location of most pineal tumors infratentorially and in the midline would give the infratentorial supracerebellar approach several advantages. Continuing with open surgical approaches. These are most effectively performed with the patient in a sitting position, whereby gravity would allow the cerebellum and the tumor to drop downward. Now, these tumors could be dissected more easily off the deep venous system and the velum interpostium. The deep venous system lies dorsal to the mass, thus making it more avoidable through most of the tumor dissection. The approach, though, is less favorable if the tumor has a significant supratentorial or lateral extension, although with appropriate extra long instruments, even tumors extending anteriorly into the third ventricle could be removed. We have the posterior approaches to the pineal region. These can be broken down into supratentorial and infratentorial. So the options for the approaches, for the supratentorial are the posterior interhemispheric, transcallosal, intervenous or paravenous approach, the posterior transcortical transventricular approach, the occipital interhemispheric transtentorial approach. And then there's the infratentorial, where the approach would be the infratentorial supracerebellar transventricular approach. Right, so starting with the posterior interhemispheric transcallosal intervenous or paravenous approach. The posterior transcallosal approach, this gains access to the roof and the medial part of the atrium of the lateral ventricles before entering the posterior third ventricle. Now, this is achieved by splitting the splenium of the corpus callosum and is contraindicated in patients with preoperative hemianopia, contralateral to the dominant hemisphere due to the risk of ataxia. It's ataxia, excuse me. Now, because of the lateral ventricle extending laterally in this region, the lateral part of the atrium is not well visualized by this route. Preoperatively, as in the anterior approaches, we would need a magnetic resonance venogram or cerebral angiogram, which would help guide the placement of the craniotomy by visualizing the dominant cortical draining vessels. Now, the position for this approach, the patient is positioned in the park bench position as seen below, with the parietal area of the operated side in the dependent position, allowing the hemisphere to fall off from the falx and minimizing brain retraction. A craniotomy begins at the posterior edge of the postcentral gyrus and extends approximately 4 centimeters posteriorly, exposing the superior sagittal sinus, and it extends laterally approximately 4 to 4 centimeters. The dura is then reflected medially, with care being taken to maintain the large draining veins in this area. So then the parietal lobe would be gently retracted approximately 2 centimeters. Next, we would go on to arachnoid adhesions being open, and the distant pericallosal arteries and splenium would be identified. Below the splenium, the internal cerebral veins join the Gland's vein, and the latter could be seen once the splenium is cut. So the splenium is incised with a bipolar cautery, and incision is made lateral to the midline because of the atrium of the lateral ventricle deviating laterally. Following access to the lateral ventricle, the choroidal dissection is performed medial to the lateral ventricle choroid through the tenia fornix, separating the choroid from the body of the fornix. The choroid plexus is either removed or reflected laterally, and this would minimize contact with the posterior choroidal artery and the superficial thalamic veins. And once the choroid is reflected laterally, the velum interpositum, the ICVs, and the medial posterior choroidal arteries could then be visualized. So now at this point, the internal cerebral veins are separated and a plane is developed between them, and this would be the intervenous. Alternatively, you could have the internal cerebral vein being dissected from the ipsilateral fornix to expose the third ventricle, and that would be paravenous. So the last layer in this approach would be to split, is the approach to be split is the third ventricle choroid plexus, and which must also be separated along the midline. The next approach is the posterior transcortical transventricular approach. So in this approach, the patient is also placed in a park bench position. A parietal craniotomy is performed with being mindful of avoiding all the visual pathways of the parietal lobe and the speech areas at the junction of the parietal and temporal lobes. The lateral ventricle is then accessed. The body and crus of the fornix at this level fill the interval between the choroid plexus and the lower surface of the corpus callosum. So this approach would expose the calcic avis of the bulb of the corpus callosum in the medial wall and the pulvinar in the anterior wall and the collateral trigone of the floor in the floor. The posterior part of the third ventricle is then accessed via opening the choroidal fissure and opening along the crus fornix. So this approach too could lead to interruption of the optic radiation, causing visual deficits, and it leads to disturbances in the visuopatial function. Sorry, I think there's an error there. In the dominant hemisphere, though, it may lead to aphasia. Gertman syndrome could also result if the inferior parietal lobe of the dominant hemisphere is incised. So this image here is just showing you this particular approach. Next, we have the occipital interhemispheric transtentorial approach. Now, this approach is usually used for pineal and posterior third ventricle lesions with either supratentorial or infratentorial components. So the patient could either be sitting or in a park bench position. In a park bench position, though the operative side is usually right and is placed lowermost, allowing the occipital lobe to fall away, reducing the need for retraction. In this approach, a U-shaped incision is made with its base, and occipital craniotomy is done exposing the posterior sagittal and transverse sinuses. The dura is then open with its base on the sinuses. Minimal retraction of the occipital lobe would be necessary with adequate CSF drainage and brain relaxation. There are really significant draining veins from the medial occipital lobe into the tentorium. Right? So the next approach is the infratentorial supracerebellar transventricular approach. So this approach is well suited for midline tumors in the pineal region, and it avoids retraction or manipulation of the cerebral hemispheres. It's not optimally suited if the tumor infiltrates laterally or superiorly above the tentorium. In this approach, a patient could be placed in a sitting position, the park bench position, or even in a prone position. The sitting position, however, would be optimal for brain relaxation and allowing the cerebellum to fall away while venous drainage is optimized. Now, to note, if the sitting position is chosen, the patients are usually at a higher risk of air embolism. So to manage this, we would place a central line. We'd have CO2 monitoring, PEEP, and compression stockings would also be advised for these patients if they're placed in this particular position for surgery. The incision would be made along the midline, and there would be a wide suboccipital craniotomy performed, exposing the transverse sinus and the torculum. The dura would then be opened with its base superiorly. Retraction could be applied superiorly on the underside of the tentorium in the midline, while gentle inferior retraction can be placed on the vermis. For this approach, care should be taken to coagulate and divide the cerebellar bridging veins as they drain superiorly into the tentorium. All right, so the arachnoid is thick and it should be divided before the pineal vessels and the tumor are visualized. The precentral cerebellar vein connecting the vermis to the Gland's vein could be sacrificed in order to gain access to the pineal region. Resection of the tumor proceeds inferior to the Gland's vein, the ICVs, and the Rosenthal's basal vein. The quadrigeminal plate should also be well visualized. And after tumor resection, communication of the posterior third ventricle could be confirmed by direct visualization. So this is just an image of this approach and the identifying structures. Right. Right. And these are my references. Thank you.